Now, our next topic is one that we kind of touched on earlier. It's integrated care, a new setting for the future delivery of healthcare. Basically, how we can better care for patients in their own areas, not in the hospitals. So, integrated care is one of the HSE's most significant programs. Integrated care aims to join up health and social care services, improving quality and putting patient outcomes and experiences at the centre of everything we do. It means changing the way care is provided so that people with complex needs can live healthier and more independent lives. Now, we're joined now, thank you very much, by Professor Martin O'Halloran, Techrete Professor of Medical Electronics, University of Galway, Professor Michelle Canavan, Consultant Geriatrician with Saolta University Healthcare Group, and Ciara Breen, Occupational Therapy Manager with the HSE. Thank you. I'll introduce the panel to you first, and then a little bit more, and then we'll open it to the audience, okay? Professor Martin O'Halloran, first of all, he's the university's first ever academic appointment to span the colleges of medicine and science and engineering in 2015. He is the executive director of the BioInnovate program and co-lead of the Health Innovation Hub program in Galway. He's a 6-time recipient of funding from the European Research Council, and he is named inventor on 27 medical device patents and was co-founder of Luminate Medical, a Y Combinator funded company. Now, Professor Michelle Canavan, Consultant Geriatrician with Saolta University Healthcare Group, you are perfect. I'm only getting to know you now, thanks a million. She is Consultant Geriatrician and Clinical Lead for Galway Integrated Care Programme for Older Persons. Michelle has developed orthogeriatric service at UHG in conjunction with the National Hip Fracture Database. Professor Canavan is the newly appointed Established Professor of Older Adult Health and Consultant Geriatrician at the University of Galway. And Ciara Breen is occupational therapist of over 20 years experience, the majority of which clinically has been in stroke, older persons and neurorehabilitation in both Ireland and Australia. She's been OT manager in Galway University Hospital since 2017, but she's imminently taken up a national role as HSCP lead in the National Clinical Programme for Stroke. She is also HSCP lead to the National Working Group on Long COVID. Thank you all very much for joining me. I'm going to keep the iPad with me just in case you want to fire a question here into the iPad, and I'll join you over here. Michelle, maybe to yourself first of all. Breda Crehan-Roche mentioned there earlier on, she mentioned integrated care. Can you describe integrated care and what's happening in the region, and how does it all fit into the national context?
Yeah, is this working? Yeah, okay. So thanks very much for the opportunity to talk. So I've been involved in developing integrated care over the last 3 years here in Galway. And that came from, I think Michael Dowling referenced there, you know, being innovative and looking for other solutions outside of how we normally do things. We had an A&P in Loughrea where, you know, we decided, well, could we offer a clinic out there instead of people coming into Galway? And that was the kernel of the development of integrated care here, where we developed a kind of a pilot program. We started seeing people in primary care, actually. We were going out there rather than patients coming into the hospital. And I suppose that's it. It's a simple model. Patients want to have care close to their home. They want to get the specialist care that they should get. But, you know, they don't necessarily want to come in. One of the biggest feedbacks we got was trying not to find parking in Galway University Hospital. Like when they can go to their local areas, it's much easier for them. But yes, it's important for us to provide the right people to deliver that care. So having the multidisciplinary team, you know, working with advanced nurse practitioners and having that available to people in their community in conjunction with the primary care teams that are already there. And I mean, I think we've talked a lot about integration here. Integration is a difficult piece because we've all worked in our siloed traditional ways. You know, I trained in the hospital, nobody trained me in integrated care, but you know, this is the way it's going, and this is how we have to move forward. And I think there's just huge opportunities to develop that further, and we have been thankfully funded through the National Older Persons Programme, along with ECC programmes, to deliver that kind of care in the West region, and we look forward to developing that further.
Thanks. Michelle, actually, and Ciara, were you going to have a presentation at the start?
Yeah.
You were, weren't you? I have jumped too far ahead with my panel discussion. Sorry, guys. Would you mind taking to the podium then and doing the presentation first of all? And excuse me, I was ahead of myself. So I'll let you do the presentation first of all. Thank you very much. My apologies.
Future that starts here.
So just going to talk a little bit about myself and Ciara both going to just talk about our experience of integrated care and how we feel it's such a good setting to actually, to be the future of healthcare, and also what we need to do to enable our workforce to be appropriately trained to be able to deliver this care. I do have my geriatrician hat on, so I'll probably focus on older people a lot, but I think, as we've mentioned, this is the future in terms of the ageing demographic and how we actually provide care to these patients. Is that moving? Sorry. So we are in the decade of healthy aging. This is designated by the UN, and this is underpinned by a vision of older people living longer, healthier lives, independent and at home. And I suppose, when we think about the why, this is why, how we need to be planning our healthcare. We need to be able to provide end-to-end clinical integrated care. We need to do that, and we need to provide that by healthcare professionals that are trained to work in an interprofessional manner, because it's not just about the doctor, it's not just about the nurse, it's about how we all work together and how this complex health ecosystem actually works together. And I think we need to, push the boundaries a little bit and think outside of our traditional system, and how do we manage to do that to provide the care that's important to older people particularly, but to all healthcare users, and develop sustainable services. So here in the West, we do have quite a frail older population, and that is increasing. You can see from the graph there on the right. And we have unique challenges here. We have, I was touched by what Michael said about, what works in Dublin doesn't work in the West, and that's true. We have geographical challenges. We have health equity challenges. People have been able to access health. And that's something that I suppose is also an opportunity. And I think in terms of retention of our healthcare professionals to be able to deliver that care, we need to think about how do we attract them to University of Galway, I suppose, to do their undergraduate careers. How do we promote their postgraduate careers, and how do we encourage them to stay here and work here and to deliver that healthcare for the people of the West. We've mentioned a lot about the changing interface of healthcare, and this is true. We have the regional health authorities coming, and I think, as Tony and Breen mentioned, this is a huge opportunity for us to actually shape what we want for the patients of our region and what their specific healthcare needs are. This has to be driven by patient engagement and patients telling us what they want and what they need. And then we build a system around that, not just what's convenient for me to run a clinic in the university hospital rather than going out to Tuam or Loughrea or wherever the case may be. I think how we and where we train our health professionals is hugely important. The role of interprofessional learning. Integrated care is actually a great space, I think, to reinvent that whole idea of interprofessional learning and how we do that, particularly with the advent of the ECC programs where we have chronic disease management and diabetes, heart failure, COPD, and respiratory problems, along with older persons who have a bit of everything. And we need to be able to work in that way. We're not often trained that way in university. We work in our little silos. There's elements of it within each course, of course, but I think we need to maybe have a bit of more focus on bringing that into the curriculum at an early stage and also right through the postgraduate course. And lastly, and I know Martin will touch on this, how we use research and technology to improve care for older people. We learned during COVID, telehealth, older people have become a lot more familiar with technology. Their carers certainly are. We're able to facilitate a lot of things using technology to enable patient-centred care and devices to help people stay independent at home, but also how we use technology to educate. We do a lot of regional education around with our academies, and there's been a huge amount of work in simulation, and integrated care is a great area to do simulated learning in an interprofessional way. So this, I won't go through it all, but it was one of the future visions. We came up with the National Programme for Integrated Care about what is our vision for older people here in Galway. And it's complex, and every arrow on that diagram really represents a patient or a carer's interaction with us as healthcare professionals, with their GP, with the consultants, with the hospital. And we just really need to think about how we build that interdisciplinary working, because it is complex. We talk a lot about integration. The integration is the hard bit, because we're all used to working in a certain way. And that's what we need to change, and I think that's what we need to have coming through in our healthcare programs at the university. So we've mentioned before what works. The optimal model of care, particularly for older adults, is care close to home, care that's coordinated, that they can actually access. Having somebody to call when you're in crisis and being able to get the cascade of all the healthcare going at that stage. Alternatives to hospital admission and healthy ageing and health promotion have to be the core of what are we trying to achieve here. It's coming. So this is the older person's chronic disease model, and Michael Dowling mentioned how it's not hospital centric anymore. We spend so much time and money up on the right hand part of this diagram, but we actually need to think about how we shift that to the left, and how we develop this integrated healthcare that's responsive. And it's not just one or the other, it's actually a whole spectrum of care that people will travel in between various aspects of it as and when they need to. The collaboration with our GP colleagues has been huge for us in integrated care, where we can, be in the primary healthcare centres, and it develops all other kinds of relationships now. We're involved in primary care team meetings, all the learning that comes from working together. Some of the programs, Michael Dowling mentioned a lot about the ambulatory programs, and this is certainly, and Ciara will touch on this as well, the importance of reablement for people at home, in their own homes. It works much better than them going to a rehab setting if appropriate. Early supported discharge following stroke, and then the benefit of integrated care teams and appropriate step-down facilities where people can actually get rehab, get back on their feet, and then get home. But we need to look at this in a different way in how we provide it. And just to mention, I was starting there in the talk around how we develop this kind of hub and spoke model for care. We talk about the challenges of accommodation and finding space to see patients, which a lot of doctors coming into new consultant roles have that challenge. I didn't have much clinic space. We got an opportunity to maybe work with one of the advanced nurse practitioners out in the community. And we said, well, why don't we start up a clinic here? We worked with the local GPs. We got them on board, and we kind of rolled that model out in Tuam area, where now we have a new colleague started. We're going to roll it out in the West Galway area, because everyone coming into the university hospital doesn't always work. So it's been a very successful model. We got funded by Launchcare for the pilot, and then it was thankfully brought into the ECC funding. We've taken 700 outpatient appointments out of UHG since we started, and we're heading for over 2,000 attendances between the Galway West and East teams this year. And I suppose we just wanted to branch that model out. I'm just talking about Roscommon, Galway, that's what I've been involved with, but also with the same thing happening up in Mayo. And it is, the strength of this has been the development of relationships between ourselves and Community Healthcare West. Because as Michael said, it's not just the medical piece, it's the whole other social care piece that goes along with minding these patients. And that is the essence of integration, I think, this cross-organisational collaboration. And I just put up a few quotes because I think that's exactly what we're trying to say here. People find things convenient, they find they're being listened to, and that patient voice is so important. We need to listen to them in terms of what they want for their care in their later years, and how we best provide that. And I'm going to bring Ciara in here to finish off.
Thanks, Michelle. So I'm going to talk you through another example of how this looks in practice. So how does integrated care come down from those principles of integrated care, and what does it actually look like at the level of patient interaction? And one example of what it looks like is this sort of team, which is an older person's reablement at home team, which delivers rehabilitation care directly in the person's home by a highly skilled multidisciplinary team. Now, this is a very successful team, but that's not what we're here today to tell you. It does save lots of bed days, and it's very suitable for the organisation. But really, the essence of it is how do we scale up these sorts of teams so that we have teams who are able to leave the safety blanket and the security of what we know. We know that moving left is a change, and we have to attract people to jobs that look that way, that by selling these sorts of models and by really showcasing how they can work for patients as well. More than with Michelle's quotes, the satisfaction with moving rehabilitation to people's homes is really evident across the board, and evident in our team, evident across the country with regards to ESD and stroke teams, and internationally evident as well. Patients want to be in their own home. Never mind the Michelin chefs, they want to be in their own kitchen eating the comfort food that they want. They want to be sleeping in their own beds. They want to be petting their own dog, maybe. So, part of it is about the best place for people to recover from the very, very acute piece that needs to be in hospital, is then often in their own homes. However, to deliver that, we need to work in different ways. Oops, sorry. Sorry, I thought I'd gone backwards there. I've gone forwards, which is always good. So how do we train the healthcare professionals to deliver this care? This involves, really development at undergraduate level, as Michelle referred to. It won't happen downstream unless we create it upstream. And that means that we need to plan at higher levels, of education to create opportunities for students, undergrads and postgraduates to learn, because there's also a lot of us still knocking around the health system with the old ways, and we also need to be upskilled and also need to be challenged and showcased how to create new ways of working. So we need to do that. And then within our institutions, we also need to meaningfully value integrated care as well. If we don't plan in a multidisciplinary way, it won't happen at the level of the patient either. And so really it's like a stick of rock where every time you slice through, it should be integrated. And if there's a gap in that connection, it really won't happen in a meaningful way at the level of the patient. So we need to recruit and retain skilled workforces. And I can tell you that when it works, it is a magnet. It does work. The Oprah service is one of the shining lights in our occupational therapy team, in our older person service. Same for ESD stroke, same for ICPOP. These are services that people do want to work in because they can genuinely see the impact at the level of the patient. That's why most people go into healthcare. There's also a role for digital health and technology within this. Thinking about dispersed teams working within a community setting, often working at different times of the day, of the week, with the same client. How do they come together to create a meaningful wraparound level of care for that patient? It involves things like digital notes. It involves, access to the various different strands of care that are needed. And it also means maintaining connections in all directions. So maintaining connections across the diagram that Michelle presented, maintaining connections back to the consultant if that's needed for an acute or a concern that's needed, equally maintaining the same levels of connection with the home help that's working with that patient and will be for the next 4 years. We also need that academic leadership and mentoring, and most of all, we need that culture change. We need the embracing of these new ways of working. These are not add-ons. This is a radical shift, and this is what we need to kind of embrace and take on if we're to make it work for us in this region. So in terms of planning for integrated healthcare, we've spoken already this morning about training, attracting and retaining skilled healthcare professionals. This is and can be a really, really positive way of working. This is what we want. It's demystifying some of that by really talking about the good work that is occurring in small teams and pockets and really scaling up what can be scaled up. A lot of this is about feet on the beat and really actually the potential for scaling. All of these, it's a simple idea, but when done well, it can really have a meaningful impact. The digital health technology that obviously Conor Judge has referred to in a lot more detail this morning are huge enablers for this type of work. And then driving clinical excellence through impactful research and policy development. So funding needs to follow this as well, and also leaders need to come out of this as well. So it's not just about having teams on the ground that are following a recipe book. This is about actually leaders coming through, like Michelle Canavan, in terms of integrated care, and actually really, seeing that being voiced and communicated throughout our health service. All of this is going to lead to one of the answers to the challenge of living well in a healthy aging way at a population level for the region. Thank you very much.
Thank you. Thanks very much, Ciara Breen and Michelle Canavan. That was brilliant, and I'm really sorry that I jumped ahead there earlier on. We'll welcome any questions now from the floor about this particular topic as well, but Martin, maybe I might bring you in as well now, since well, Ciara kind of touched on it there about the digital solutions, but are there any strong examples of digital health solutions in medtech that are already delivering benefits for patients?
Yeah, I think there's some ones I think are really inspiring. So there's technologies that's been developed in the last, I think, 5 years for heart failure patients. And where this came from is in the US, they did an analysis of the number of heart failure patients that were readmitted into hospital. And each readmission was costing something like $17,000. So they said a lot of the reason for readmission is just unoptimized medication. So a couple of companies now have developed technologies where you can monitor continuously the blood pressure of patients. And so that allows, if a heart failure patient is discharged, their blood pressure starts to increase, the clinician gets alerted and they can modify their medication. And so they never end up back in A&E. And I thought that was really interesting. I was talking to a clinician in Ireland who's involved in that trial, and I said, what impact is it having on you? And he goes, I just don't see these patients in A&E. So they're staying at home, the acute event doesn't happen. So I think that's really inspiring. I think the challenge with it is that where medtech as an industry is innovating is in areas of very significant cost. So you can do that in heart failure because of the costs associated with heart failure. I think in more rare diseases or more rare conditions, the economics are more problematic. And so I think it's thinking smarter in areas like that.
Very interesting. And in the whole area of communication as well, for example, if there's a patient, for example, in Leenane in County Galway, public health nurses going out to him, maybe different services. But is there a lack of communication? Is it difficult to kind of keep track of the progress of this patient, for example? We don't probably have the communication system to do it, do we?
So I'm going to pass over that question, but just to say, I think.
Or could it be developed?
I think it's a really good point. So it's often it's not a technology problem; it's an integration problem. So we have the solutions, we have the technology. So I'm saying this as a technology person, but the technology exists and it's in other sectors. But it's how do we integrate that into the health service?
Is it there already, Ciara?
I think there's some elements that are there in part, I think there's definitely a lot that's happening in terms of that communication piece. Certainly for us, a huge advantage has been moving to electronic healthcare records, because it means that when the person's in the home, they can actually, check in, see what's going on, be up to date with the clinic appointment that maybe happened yesterday. So those are huge enablers. It sounds, really simple, but also that stops then when you go outside of the hospital network. So it's a different system then for some in terms of community. Yes. So for example, you may be on different systems, not everybody has the same access, and obviously GDPR issues and things like that are very relevant concerns, but there's sometimes we need to think disruptively about how we can create those pathways and connectivity, I think, between it, because there are the opportunities there to resolve those issues.
Oh yeah, big time. Yeah,
just to echo exactly what Ciara and Martin have said, but I see patients in clinic if I'm out in Portiuncula or Loughrea, and they say to me, well, why can't you see what happened to me in Portiuncula, because I only have access to the Galway system. There's a 90-year-old patient in a clinic in East Galway, so they see it, and they think we can actually see all their data, but yet we get hung up in the bureaucracy around GDPR and all that, and I'm not saying that's not important, but I think we need to find innovative ways around how do we do that, and how do we be able to share this information, because so much of it is sharing, and equally our GP colleagues, like they can't see investigations that were done in the hospital that could be really relevant when someone comes in with a particular complaint. So, joining that up together and having all these systems is huge, and I think the opportunity for partnership within the university here because these guys have all these, they have a lot of these solutions, and how do we harness that into the healthcare setting?
Yeah. Brilliant. We have a question here from the floor as well, just this gentleman down here. Your name, please. Thomas. One second, now I'll get the microphone to you. Thank you.
Thank you. I have a question for Michelle and Ciara. Thank you very much for the lovely talks. Have you any experience of integrating the integrated care hubs? So you mentioned that, Michelle, you said that, correctly, that people with attending yourselves have little bits and pieces going on, and often diabetes is one of those. And have you any experience of integrating the older adults care hub with the diabetes care hub or the COPD or heart failure care hubs? And what's your thoughts on that?
So let's start with that, Ciara, because these hubs, although they're on the diagram, haven't actually materialized yet. So the physical integration is not happening yet, but it is a vision. And I think, you know, that idea of a place in the community where people can go for ambulatory care, and you have the presence of the diabetes team, the heart failure team, the older persons team, to be able to work together and cut down and actually create that whole integrated care pathway for the patient. So, you know, to answer your question, we do it in pockets, you know, where we can at the moment, but because we're not all located together, but we still work together. But again, it comes through to the ICT part of how we connect. Even if we can't connect in physical buildings, like how can we connect virtually? I think there's a big role for maybe interdisciplinary meetings among the various specialties, you know, located in these hubs, and that will all come. That's all part of the plan. But I think it's in its early stages, and you know, that's not how we always did things. Comes up a lot, and I think that's one of the biggest challenges that all of us have to kind of, you know, face and try and work through, because we just need to change how we think about how we deliver this care.
Yeah, mine is, I suppose, I think integrated care is, we're carving out new space, aren't we? You know, really. So I think the best integrated care doesn't have a shape in a way. You know, we have to create the boundaries that form the shape of the integrated care. And I think we can choose to create very constrained and tight boundaries, or we can choose to create more fluid ones. So I think as the walls come down a little bit between the different services, I think there'll be a lot more choosing to connect. And I think that it's that interoperability between services that will be critical to success going forward.
And Michelle, of course, this was going to be a major shift, this integrated care, but do the undergraduate and postgraduate programs, do they reflect that?
I think certainly within every program, this ethos of care is definitely reflected, you know, and that's, as Ciara said, that's why we all become healthcare professionals, you know, to deliver this care. And it's not just the type of care I can deliver, it's how the impact of the whole spectrum of care impacts on the patient. But I think there certainly is a role for maybe embedding more interprofessional learning within the undergraduate curriculums right across the College of Medicine, Nursing and Health Sciences, but also maybe to develop those postgraduate programs that Ciara talked about, you know, that focus on actually, you know, we have skilled healthcare professionals already working in our system. How do we equip those to do that integration that Tomas talked about? How do we integrate the integrated care? But people need to learn those skills, and I think the university has a lot to offer there. So I think there's definitely room for development of that whole program, both throughout the undergraduate and postgraduate curriculum.
And maybe just Martin, just maybe to finish it off, I suppose, unless there's any other question, but I suppose, you know, on a positive note, there are like lots of medical technologies coming on stream, aren't there, that's going to make this much easier in the future.
Yeah, and I think the panel has touched on some interesting points in that the bar is actually so low. Yeah. You know, if we move, like we obviously work as an engineering, we work across sectors, and you see in the automotive sector or in the mobile device sector how fast things move, and then like I work, my lab is in the hospital, so you pass by these patients and you see just the lack of technology and the lack of good solutions. So I think these kind of cross-disciplinary discussions and letting engineers and scientists see the problem and help develop those solutions. But I think the thing that always surprised me is that the bar is so low. There's so many areas that we can improve quite quickly and quite simply. Yeah,
when you see what could be done during COVID and how fast we were able to move, like it would really kind of give you some hope for the future. I'll leave it there. Martin O'Halloran, Ciara Breen, and Michelle, do you want? I know
Martin probably had a few examples in his presentation.
You maybe did. Oh, did you have a presentation?
No, I think we've covered. I suppose my point in the presentation was that, and I think we've talked about it here, is really just that those solutions exist. So it's not, I think, and I'm putting my hand up saying, I'm saying this as an engineer, the problem is not an engineering problem. It's engineering, understanding the complexity of the health service. And so I think, I suppose a lot of the collaboration that's happening now between the College of Medicine, Nursing, Health Sciences and Science and Engineering is really positive. We're bringing together those groups to find those innovative solutions. So I think some of the challenges in digital health at the moment is just people without the medical knowledge developing solutions in silos. I think that's not helpful. But I think some of the projects that are ongoing in the university and the hospital are really promising.
Martin, thank you very much. Thank you. Martin O'Halloran, Ciara Breen and Michelle Canavan. Now, Chorda, we're joined now by Honorary Professor Derek Stewart, OBE. He's going to be moved out because I think everyone's Oh, okay. I think that's a great idea, Michelle. Like, the afternoon. Okay, well listen, we're all going to take a break then. Lunch. So lunch, 20 minutes for everybody. Thank you very much.